Good afternoon, everyone. My name is Nicole Hughes. I'm the manager of Longstreet Clinic Imaging Services. First and foremost, we'd like to thank you all for joining us for this Facebook Live session. For those not familiar, Longstreet Clinic is a primary care and multi-specialty facility with 10 locations across North Georgia, over 200 providers with 19 different specialties. As you can see, we provide many services to the community. Among them is a comprehensive breast care service. That would include gynecologic services, surgical services, oncology services like chemotherapy, and diagnostic and screening mammogram services, 3D mammograms, all of the imaging services, including breast ultrasound, targeted, handheld, and automated ABUS. Our providers work hand in hand with Northeast Georgia health systems to provide seamless care to our community. In Northeast Georgia Medical Center's cancer services are accredited with commendation by the American College of Surgeons Commission on Cancer, the COC, and it's the only program in Georgia, only one of 24 programs in the nation that has received the 2018 Outstanding Achievement Award by the COC. I'm here today with a couple of members of our community's comprehensive breast care program, and I'd like to let each of them introduce themselves to you. And I'm going to start with Dr. Alfred.
Hi, my name is Brett Alfred. I'm a surgeon here at Longstreet. I've been practicing in Gainesville for 23 years. I've been at Longstreet for 13 years. And by training, I'm a general surgeon, but I have a special interest in the surgical treatment of breast cancer. And so a significant part of my practice is dedicated to that. And I've recently been appointed as the breast program director for Northeast Georgia Health System. And so we'll talk about that in a little bit. Very glad to be here. And the things we're talking about are very important to me.
Thank you, Dr. Alfred. Dr. Garlich?
Hi, my name is Cricket Garlich, and I'm a gynecologist with Longstreet. I also would like to say thank you to everyone who is watching, both now and at a future date, and to say how honored I am to be a part of this panel on this incredibly important topic. I've been with Longstreet also for 13 years, and I work out of both of our Gainesville and our Baldwin offices.
Okay, thank you, Dr. Garlich. Dr. Sun.
Hi, my name is Yamin Sang. I am the newest oncologist joining Longstreet Clinic. My practice is in Gainesville at this point. I'm from Texas, and I did my training in Texas and Maryland. I'm really glad to be here today to talk about breast cancer with everyone here.
Thank you. And Dr. Ilhamali.
Hi, my name is Adnan Ilhamali. I'm one of the radiation oncologists at Northeast Georgia Health Systems. I'm new to the area. I'm originally from Atlanta, but just relocated here from Houston, where I did my oncology training. I'm happy to be joining the event. I'm practicing in Gainesville primarily and occasionally in Toccoa as well.
That's great. Well, welcome everyone. We're here today to talk about breast health. And we've all heard the expression that early detection is the best protection. And it's why everything turns pink in October and we're all showing our support for Breast Cancer Awareness Month. And it's why so much emphasis is placed on women of a certain age or with certain risk factors making that annual trip for their screening mammogram. But why is screening so important? Today, we're going to share a few different screening options that are available to you in the area, like 3D mammography, as well as ABUS. But we're also going to go a little bit deeper into what happens if you find an area of concern or diagnosed with cancer, what treatment options are at your disposal, what can we do within our community. So the first thing we're going to talk about is what the recommendation for mammography actually is. There's a lot of information out there. Longstreet Clinic's radiology services radiologists recommend that women begin annual screening at age 40. You could potentially, if you're at high risk, check with your insurance company. Most will offer one or if not more between ages of 35 and 40. And women who have dense breast tissue, we recommend that you supplement your annual mammogram with whole breast ultrasound screening. So that being said, Dr. Garlich, can you explain a little bit about who should be having an annual mammogram and why it's important that we follow these recommendations?
Of course. So most women in our listening audience are at average risk for breast cancer. And like you said, for these women, we typically recommend beginning screening mammograms at the age of 40. Breast cancer is the second most common cancer and the second leading cause of cancer death in women in the United States. Fortunately, because of early intervention and because of improvements in breast cancer treatment, we have significantly reduced the death from breast cancer. And getting breast cancer is no longer a death sentence. It's for this reason that we encourage women to begin their mammograms and to continue routine screening as suggested by their physicians.
So there are also recommendations around routine self-exam, and I know that these are ever changing. What is your perspective on this? Is it still important, and how often should we be doing it?
So most experts no longer recommend a monthly routine self-breast exam. However, with my patients, I encourage them to know their bodies and to be aware of their breasts. And if they ever have an abnormality or a change, to please see their provider for further evaluation.
Okay, so if I do feel a lump, what would my next step be?
So your next step should be to call your physician and to schedule an appointment. And we can help determine if that is a benign hormonal change that may have occurred or if it's something more concerning and help establish imaging or referrals at that point.
Okay, great. Well, I'm going to spend a little bit of time answering some of the common questions that we get in the imaging department about the technology that we use and how patients flow through the system. So some of the modalities that are available at Longstreet Clinic are 3D mammography, and that would be for screening and diagnostic purposes, as well as 3D automated breast ultrasound, which is also known as ABUS. Longstreet Clinic's the only facility within 60-mile radius that's offering that technology right now. And then we also do the traditional handheld breast ultrasound. We always get a lot of questions about what's the difference between screening and diagnostic. And the easiest way I can explain that is that screening is for patients who are not symptomatic, who are not experiencing any problems. If you have a problem, you should have a diagnostic mammogram. And diagnostic would also be if a radiologist has recommended any kind of follow-up for you. So we're doing mostly 3D mammography. Some diagnostics are still recommended in 2D. And I wanted to talk a little bit about the difference between 2D and 3D, and is it better? Will insurance pay for it? And I think an easy explanation for 3D mammography is going to be the difference. 2D is like looking at this book, front cover to back cover, with all of the information on the inside, and you're just looking right through it. With 3D, we're able to open the book and look at your breast information page by page, and the radiologist can really assess things a lot more clearly in that way. Insurance most of the time will pay for the 3D. A lot of insurance companies do, however, require that you have a prior authorization. So if you have any questions in that regard, we recommend that you contact your insurance company. We also would like to talk a little bit about how accurate a mammogram is. And that really depends on your body's composition because it varies between breast density to breast density. So first, I'm going to tell you a little bit about different breast densities. You may have noticed, if you've had a screening mammogram in the last year or so, that there's a new part of your report, and it says that you have a certain amount of dense breast tissue. The scoring system for this is 4-part, and it begins with A, fatty breast tissue. Fatty breast tissue is easy for X-rays to see through. So women with fatty tissue pretty much can expect 85 to 95% sensitivity on their mammograms. Women, the next category is going to be B, scattered density. And that is going to be women who have just kind of here and there dense fibrous areas in that fatty tissue. And those are also relatively easy to diagnose with mammogram alone. So we're going to expect around the 80% range of a sensitivity on a mammogram. Then we're looking at C. We're moving towards more dense breast tissue, and it's heterogeneously dense C, which in layman's terms is going to mean that your breasts are comprised of half fatty and half or so of that dense fibrous tissue. Those would be the women that we would recommend a supplemental screening on, just to get a little bit clearer view of what's in between those layers of dense tissue. And then the last category is going to be the category D, the extremely dense tissue. And our radiologists do recommend that these women pursue a supplemental screening with the 3D automated breast ultrasound, because we can look at that tissue in a different way. And the best explanation for that, I feel like, is that cancers show up white on mammogram. So does dense tissue. So we have to look at it differently with ultrasound. Cancers show up black under ultrasound, and it gives the radiologist really a clearer view in an area that they can target and work up further. The last part of my little discussion of what we're offering is going to be, I wanted to let everyone know about the different sizes of masses that we can find at different stages in your care. So this little keychain represents the largest bead is what we would expect to find in women by accident. And that's about 3.5 centimeters. This 2.1 centimeter bead is going to be the bead that women would find if they did a self-exam. The next one is about a 1.5 centimeter bead. This bead would represent what you would find on your first mammogram without any prior imaging to compare it to. This 1 centimeter bead is what we would expect women to find after subsequent mammograms. A radiologist can determine a change this small in tissue from year to year. And the smallest bead is going to be what we would expect to find in women who have had an ultrasound and a mammogram together. So that being said, we obviously don't really want to find, if our mammogram results don't come back negative, if something is found, what happens next?
So like you said, most women are initially having a screening mammogram. And so for these women, there are very likely to be abnormalities detected that could in fact be benign. So the next step for those women is typically additional imaging with a diagnostic mammogram, perhaps an ultrasound. For some of those women, that will be read as normal and they can return to routine screening mammograms. For some women, those will be read as benign, but the radiologist will say, I really want to keep a better eye on this and hopefully have the patient return for additional imaging in 6 months typically. For some of those women, unfortunately, the findings will look more worrisome. And for those women, we help to refer them to our colleague and friend, Dr. Alfred, or one of his other breast surgeons who can help make a definitive diagnosis. What patients should realize, though, is that they are not alone on this journey. We are going to help them in, getting the appointments for additional testing, help them with their referrals. We will be there with them to on this journey to make sure that they are getting the best care possible.
Oh, that's really good to hear. I know that takes a lot of anxiety away from a lot of women. Dr. Sun, can you talk a little bit about the different types of breast cancer and about the medical treatment options that are available?
Yeah, sure. So breast cancer, you can classify it, there are a number of ways that you can classify it. There is non-invasive breast cancer, or DCS, ductal carcinoma in situ. Usually that means the cancer is still within the milk duct and have not invaded to anywhere else. And there is also invasive breast cancer, and they're really a number of types that, that are invasive breast cancer. The most common type is invasive ductal carcinoma, and that's probably about 80% of all invasive breast cancer. And the less common types, they're lobular carcinoma, as well as others like tubular, mucinous, and there are also even rare breast cancer like lymphoma or sarcoma. Those are extremely rare. So in terms of a treatment of breast cancer, so usually for women with early stage breast cancer or stage 1 to 3, the treatment is usually centered around surgery. So because women do need to have surgery to take out the breast cancer. And in terms of medical treatment for that, it really depends on the type of the breast cancer, as well as some of the feature or what we call receptor status on the breast cancer. And that when we look at, when people get a biopsy of the breast cancer, it was sent to a pathologist who order a number of testing that test for little protein receptors on the cancer cells. And the one we need to know are the hormonal receptors, as well as the HER2 receptors. So depending on that and the stage, the size of the breast cancer, then we formulate a plan regarding the medical treatment around surgery. Sometimes women may need treatment before surgery, and sometimes they may need treatment after surgery. Sometimes they may need both.
So if someone has to have a medical treatment for a cancer, can you talk to us about like what we might be able to expect as far as long-term side effects? Does it affect fertility in women who are of childbearing age?
Yeah, so it really depends on what kind of treatment they're getting. They are hormonal treatment where they're basically taking hormone pills. And usually, with that treatment, it also depends on what kind of hormone treatment they're taking. There are certain long-term health effects, like for aromatase inhibitor, a type of hormone treatment. The long-term health effect can include, bone loss or osteoporosis, and it also causes, symptoms that are related to hormone changes. And there's certain women that would need chemotherapy for breast cancer. And chemotherapy can certainly have long-term health effects, as well as affecting people with short-term as well. So fertility is definitely one of the things that chemotherapy can impact. And in some women, chemotherapy can make people into early menopause. And the long-term effect of chemo can also include, very rarely, there can be, with certain regimen of chemo, there could be heart failure, as well as secondary malignancy in the future. And sometimes people can also have long-lasting neuropathy, like numbness, tingling their fingers, toes. That happen. People can also feel more tired for a long time after chemotherapy. So those are some of the things we always talk to patients about if we need to put them on certain treatment for breast cancer.
Well, it's good that we have so many comprehensive services available so we can take care of the side effects of having some of these treatments as well. Dr. Alfred, can you share with us a little bit about how Longstreet Clinic and Northeast Georgia's health system are working together to care for the breast cancer patients?
Sure, I'd be glad to. There's a big collaborative effort between the Northeast Georgia Health System and Longstreet Clinic to reassess or to evaluate how we provide breast care in our community. And the system has grown larger. There's multiple hospitals, multiple imaging centers, and we want to be sure that at each location we're providing good care and quick, fast care. One of the things that we realize is that when a woman gets an abnormal mammogram report, that the stress level is immense until she can have either resolution of the problem or she has a plan for how this problem is going to be managed. And so what we're trying to do in this project is to consolidate or to shorten the time frame from when a woman gets a mammogram to get a diagnostic mammogram, to get a biopsy, to get a a plan for how we're going to manage it. And so I'm very excited about the project. I think we're going to find that we can really expedite or speed things up, and so that women don't have to wait as long.
That is really great to hear. Dr. Ilhamali, where Dr. Sun is a medical oncologist, you're a radiation oncologist. Can you talk to us about what the difference is between the two specialties?
Sure, I'd be happy to. So with medical oncologists like Dr. Sun, they use chemotherapy or systemic therapy or pills that will go all over the body and will treat, cancer all over the body. Radiation therapy is a local treatment, and it's really more similar to surgery than it is to medical oncology. Radiation has been used for decades and centuries to treat cancer. It's basically X-rays and high energy X-rays that pass through different parts of the body, and they go through the cancer in that area, and they can kill cancer cells. And our role really falls for breast cancer treatment. Typically, we do radiation after surgery to reduce the incidence of the cancer coming back either in the breast or in the lymph nodes near the breast.
So does that mean you are going to work closely with a surgeon?
Absolutely. Breast cancer is one of the most multidisciplinary cancers that we care for, meaning that there are multiple members of the team that are involved that all have to communicate and all be on the same page to deliver the best outcome, to maximize the cure and to minimize the side effects from the treatment. So we work very closely with surgeons and medical oncologists, and specifically the role of radiation when it comes to surgery is that over the years, we've learned that by doing smaller, more focused surgeries, following with radiation therapy, we can maximize the benefit to women and minimize the extent of, of surgery that they have to go through.
Oh, great. Dr. Alfred, once again, can you discuss a breast biopsy and when that might be done in the treatment planning?
Sure. So the way the system works, so a woman gets a screening mammogram. If that shows an abnormality, then she's going to get a diagnostic mammogram. And often when she has that, she gets an ultrasound as well. And then if there's still an abnormality, that something that looks suspicious, then she comes to see me. And I can look at the images and decide what type of biopsy needs to be done. And what we're trying to do is do the least invasive thing possible to get a diagnosis. And so if this lesion, the abnormality is something that can be seen on ultrasound, what I'll do is an ultrasound guided biopsy. And I take the patient, and what I try to do with these biopsies is do them the same day that they come to see me. I don't want them to have to wait. And so we're trying here at Longstreet to do these all the same day. And so I'll take her to ultrasound. The ultrasound tech will find the area, and then I'll come in and numb up the skin, make a tiny little incision, and put a needle in. And I can use the ultrasound to guide myself so that I know I'm in the suspicious area and take some pieces. And then we send that to the lab. And so if the lesion is not seen on ultrasound, then I'm going to use a mammogram to guide me with the biopsy. And that's called a stereotactic breast biopsy. And we have that equipment here in our office so that we can do same day stereotactic biopsies. There are two surgeons in my group that do these types of surgery, Dr. Strom and myself. And so we're again trying to do it the same day. The day that the patient comes in, we want to be able to provide that biopsy. But basically what we're doing is the same thing, and that is minimally making a small little incision to obtain a biopsy of the suspicious area to try to get a diagnosis.
So once you send it off to pathology and get information back, how do you tell what the stage is of the cancer, and how does it benefit the patient to detect these things early?
Sure. So the way I work it is when I do the biopsy, I can usually get pathology back in 2 to 3 days. And so I tell the patient that I'm going to call them when the results are back. Usually I try to in 2 days, and then let them know what the result was. And then if it's something that we have more to do, I'm going to get them to come back to the office so that we can have a conversation. I do want to say that most biopsies are negative. They're benign. And so just because somebody's having a biopsy doesn't mean they have a breast cancer. But it's still important to do the biopsy to prove it, to be 100% sure that there's no problem. And so when I get the result back, I'll call the patient with the result. I'll have them come back and see me. Well, the quicker that you can get to something, and the smaller, say it's a breast cancer, the smaller the cancer is, then the least chance it has of spreading and causing problems down the road. And so the staging of a breast cancer involves the size of the tumor, whether there's any lymph nodes in the axilla, the underarm, that are positive, and whether there's any evidence of spread to any other parts of the body. And so obviously, the lower the stage of the cancer, the better it is for the overall prognosis. And
so that's
I
why
can't encourage people enough. I can't encourage people enough to get their mammograms, and because we're going to find it as early as possible, and then the treatment's going to be much more effective.
that's really good information to have. Dr. Garlich, what do we know about the causes of breast cancer? And if you would want one thing to transcend to the women who are listening to remember most about their breast health, what would that be?
Well, clearly we know that there is a genetic component to some breast cancers. And so it is important for women with a family history to discuss their family history with their physician and to see if they are at a higher risk for breast cancer. However, family history only accounts for about 10% of diagnosed breast cancers. And so for women who come to see me and we're discussing scheduling their screening mammogram, I frequently hear, but I don't have a family history. And so it's important for those women to know that most women who develop breast cancer do not have a family history. And that's why we recommend screening for all women, regardless of history. The thing I think I want women to know most from their breast health and take away from this presentation is that breast health is your health. And so as women, we very typically put ourselves behind our family members, behind the needs of others, and we don't always go in to get our annual exams, our mammograms. And if I can encourage them to do anything, it's to make sure that they are getting these screening exams and having preventive medicine, because it's so important to, finding these cancers, preventing, other cancers, and making sure that we're staying healthy so that we can take care of our families.
Thank you, Dr. Garlich. Dr. Ilhamali, are there ways that we can reduce someone's risk for developing breast cancer just across the board? And like Dr. Garlich said, what if it does run in someone's family? Is the risk greater for them? Well, would anyone like to jump in on that question?
Sorry, I think
he was just.
There he is.
Yeah. So the number one risk factor for developing breast cancer is aging. And unfortunately, there's not much we can do about that factor. And so as Dr. Garlich mentioned, the most important thing really is to obtain routine screening mammograms starting at the age of 40 and have that discussion with your physician, because that's the number one way to reduce the risk of having complications or developing an advanced breast cancer. There are other risk factors that have been shown in large studies. Now, whether changing those risk factors is possible is not entirely clear. So we know, for example, that obesity in postmenopausal women can be associated with breast cancer, that alcohol consumption can be associated with breast cancer. But really, those risk factors are mild compared to the risk of just developing breast cancer associated with aging.
Okay. So you did say that, we can test the risk. Dr. Sun, do you want to talk a little bit about the ways to test risk and a little bit about, I heard you say HER2, when should these kind of things be conducted?
Yes. So there are genetic testings available that can test for if if anyone has a genetic mutation that predispose them to, develop breast cancer or even other cancers. Usually, for breast cancer patients that come to see me or, see other, Dr. Alfred or other oncologists, and, we would ask about what their family history is, cancer, not just breast cancer, but other cancers as well. And there are certain, I would say, criteria or guidelines that are available that would guide us into, okay, does this person need a genetic testing, which is a blood-based test. So the blood is drawn and sent to a genetic testing company and to see if there's any genetic mutations that are related to the breast cancer. And for patients that are not a breast cancer patient, but they do have a family history of breast cancer, like if they're they have a multiple breast cancer on on one parent's side, or they have siblings that have breast cancer, especially or if they have got breast cancer at young age, there's a certain threshold for even if it's just this one person getting even just one person getting breast cancer, for people that don't have breast cancer diagnosed but do have suspicion or concern they may have something wrong in the family regarding this, and then we would recommend them to see a genetic counselor where they would actually kind of run through the whole family history and make a recommendation regarding what kind of tests they should get, to look at their genetic backgrounds. So in terms of the HER2 test, so HER2 is a protein sort of on receptor on the cell, on the surface of the cell, and this when the gene that sort of tell the cell to make the HER2 protein is over expressed or amplified, meaning there are a lot of proteins that are being produced. Then people, we do have special treatment for this kind of HER2 positive breast cancer. So and this test is only done for women with invasive breast cancer. It's sent straight from the biopsy specimen or from the surgical specimen that was taken out, and to a company that tests for this, and the patient does not need to do anything on their end for this test.
Okay, thank you. Dr. Alfred, can you talk a little bit about why genetic testing might be important in treatment planning from your surgical perspective?
Sure. It's important for the women that meet the criteria to have genetic testing to get that done before surgery, because it could definitely affect the type of surgery that I'm going to do. And so the five main criteria are a woman under 50 that has breast cancer, a woman with 2 or more primary relatives that have breast cancer, and that means mother, sister, daughter, any man that has breast cancer, any woman that has bilateral breast cancer, cancer in both breasts, and then there's a special kind of cancer called triple negative cancer that's very aggressive. And so if any one of those 5 criteria come to see me, I'm going to do the genetic testing, because if they have an abnormal gene, it may very well mean that they need bilateral mastectomies as the surgery, and they really don't have the other options that they might have otherwise. And so it's very important, and we've certainly gotten a lot better at genetic testing, but it's very important for the appropriate patients to have that done preoperatively.
Okay. Well, I know that we've already said this a few times about how important it is to come in and have your screenings, that regardless of the circumstances, that early detection is going to be key. Does anybody want to say anything about what we're doing to make it safe for patients during these uncertain times with COVID and everything? What are we doing in our offices to make it easier on people?
In our office, we are bringing women in, at times so that they're not spending a long amount of time in the waiting room. We're getting them back into the exam rooms as quickly as we can. We are sanitizing rooms between patients to make sure that we are keeping everyone healthy. And, we're just really trying our best to facilitate women coming in. We're doing some telemedicine visits, but clearly if you are worried about a breast concern, we need to see you in the office. But that is, we're trying very hard to alleviate the additional fears associated with COVID so that women can come in and get their care.
I know that when things were shut down for several months, nobody was getting a mammogram. And so I was worried about that, because it doesn't mean that breast cancer went away. It just means we didn't know about it. And so again, just want to emphasize, continue to get your mammogram when you need, when you're supposed to.
Yep. Absolutely. I know the imaging department is definitely observing social distancing. We're trying to keep patients safe by bringing them back to the dressing rooms one at a time, and everything is fully sanitized in between every patient in every room. So it's much safer to come in and find out and get an early start on things than to wait because of a fear of what's going on in the environment right now.
You also want to say, for
Anyone else?
in terms of radiation therapy, in the clinics, we're taking the same precautions, using telehealth visits when appropriate, sterilizing the rooms. Also, in terms of the radiation equipment, the radiation table, treatment table, and the equipment gets sanitized after every single radiation treatment. And in the incidents when we do have a patient who, tests COVID positive, those patients are treated at the end of the day, and then the equipment in the room is completely sterilized after that appointment.
Thank you.
I did want to bring up one other thing. I wanted to bring up one other thing that I didn't talk about before, was when the patient first comes to see me and they have a diagnosis of breast cancer, what I do is go through the surgical options that they have. And what I want to do is offer the least invasive surgery possible that will still be an adequate cancer operation. And so often we can do a lumpectomy, which just means taking the tumor out, and the patient can keep their breast. If they have to know that if they have a lumpectomy, they will need radiation treatment to their breast. But there is no difference in the curing of the cancer if you have a lumpectomy with radiation as opposed to a mastectomy. And so if I can offer that, that's what I want to do. There are some women that have a big tumor or have several tumors in the breast, and those women would need mastectomies. And then you can also offer a mastectomy with reconstruction, and we get our plastic surgery colleagues involved in that as well. So often a woman has multiple options as far as surgery, and it really is her choice what she decides to do.
Thanks, Dr. Alfred. Did anyone else have anything they wanted to add?
Yeah, I just want to say, we all understand we're still in the pandemic, but if any women or even men does have a concern regarding their breasts, please don't hesitate to come in. I have seen a number of patients that kind of waited for several months before coming in, and their breast cancer has grown much bigger. That would really mean they would require more treatment. Sometimes, like I said, even intense chemotherapy to kind of, treat the breast cancer. So I think even if it's just a small nodule, small lump, don't hesitate to come in to get a, mammogram, get to be seen by a doctor, so that, it's much better to take care of it when it's still a very early stage than, if it's a much, bigger breast cancer.
Well, thank you, everyone. And thank you so much, Dr. Sun, Dr. Alfred, Dr. Garlich, and Dr. Ilhamali. I appreciate everyone taking their time to answer these questions with me today. And I wanted to thank everyone who took time to listen in. We appreciate your dedication. Also, we know, as we've all said, that it remains a really uncertain time, but we are all taking as many precautions as we can to keep you safe. Don't delay your care. It's so much riskier to delay care. Please, please, please go out and get your screening mammograms. Now is the month to do it. We have a few more days. And if you need to make any appointments, please do it either through my chart or calling into our office. And if you want to reshare this post, if you found any of this information useful to you, useful to your family or friends, please do so. We've really enjoyed all the interest that everyone's had in our Facebook Live sessions. And if you have any questions that we didn't get to answer today, please call our main line at 770-718-1122. And in the meantime, just know, guys, that we're all in this together. And remember to do everything that you can do to help stop the spread. Wash your hands as often as possible, wear your masks, and more than anything, watch your distance. Thanks again for tuning in, and I hope everyone has a wonderful afternoon. Stay well.